All right, let's begin. Welcome everyone to our YouTube channel, NCLEX Crusade International. This is day number 9 of our live training, how to pass the NCLEX. Basically, if you are a nursing student, you are preparing for the NCLEX, our YouTube channel, NCLEX Crusade International, can guide you and help you with your NCLEX preparation. So thank you for joining again. And in tonight's training, we're going to be talking about bradycardia, sinus bradycardia. So as you know, if you're here for the first time, let me know in the comment section if you're brand new, if this is the first time you're seeing a live training, and let me know where you are connecting from. I always like to know my audience, where they're coming from, and we give you a warm welcome to our YouTube channel. Remember to subscribe to our YouTube channel so you don't miss any of the information, any of our live training. If you're not subscribed and you don't activate the bell, you would not be notified that we are live and you could miss one of these very interesting trainings. Okay? Also remember to like our video. It will help us out a lot. So if you're brand new and you haven't seen day 1 to 8, make sure you go back to our channel and review the previous 8 trainings that we have done. They're actually very, very good, and it would help you tremendously with your NCLEX preparation. And like always, make sure you find our 3 7-day trainings that we have on our YouTube channel. One on priorities, one on pharmacology, and the last one that we did focus on the Next Generation NCLEX. Okay, so I see a few of you saying here for the first time. Welcome. Excellent. All right, let's begin. So here is the question we're going to be discussing tonight. It's going to be, or this evening. I don't know why I keep saying tonight. This is the question we're focusing on this evening. Basically, a client develops sinus bradycardia with a blood pressure of 90/40 and a heart rate of 46 beats per minute. Which of the following actions should the nurse take? If you know the routine, I give you the question, I give you the opportunity to analyze it, but before I go to the answers, I like to talk a little bit about the topic discussed on this NCLEX style question. Okay, so remember, I'm going to give the answer at the end of the video, but before, I want to talk to you about bradycardia. What is sinus bradycardia? Sinus bradycardia occurs when the SA node creates an impulse that is at a rate lower than 60 beats per minute. So if it's less than 60 beats per minute, if it's the SA node, the one that is creating a slower beat, this is known as sinus bradycardia. Bradycardia can represent a very serious problem to our patients, especially when they are symptomatic, because the heart with a extremely low heart rate cannot pump enough oxygenated blood to the body. Now, you should know that there is an exception to the rule, and this is a good NCLEX tip, because a healthy young adult, trained athletes, they can manage a resting heart rate below 60 without manifesting any clinical symptoms. And you may ask, why? Why an athlete can have a resting heart rate of less than 60 and be completely asymptomatic and show no symptoms? Because athletes, due to their training, they have a physiologic adaptation to manage a lower heart rate, and the reason is because of a physiologic cardiac dilation, that the patient can have a low heart rate and still maintain an effective cardiac output. That is the physiological reason why a trained athlete can have a bradycardia and be completely asymptomatic. Now, so you can really understand what is going on in sinus bradycardia, we have to talk about the normal cardiac electrical conduction. Okay, so we're gonna go back to a little bit of anatomy and physiology and recall a little bit of the normal cardiac electrical conduction. Okay, so basically, when we talk about the normal cardiac electrical conduction, there are some structures that you need to remember. Okay, and let's talk about these structures. As you know, we have the SA node, which is the natural pacemaker of the heart. So we're going to be talking about the SA node. We're going to be talking about the AV node, or atrioventricular node. It's called atrioventricular because it's in between the atria and the ventricles. We're also going to talk about the left and right bundle branch, the bundle of His. We're going to talk about the Purkinje fibers. Okay, so you understand the normal cardiac electrical conduction, and also some important properties that influence the heart rate and contractility. So the SA node, here is the SA node. The sinus node is located in the posterior wall of the right atrium near the entrance of the superior vena cava. It basically generates by its own, without any other organic control, it generates by its own electrical cardiac impulse. And this property is known as the cardiac automaticity property. So it doesn't need any other stimuli to produce its own energy and produce a heart rate. Now, you need to know, let me see what's going on with the camera here. It's a little bit cloudy, a little bit, there you go. The peripheral nervous system can directly modify this action. Okay? For example, it can produce an increased heart rate with a sympathetic effect, or can produce a decreased heart rate with a parasympathetic effect. And of course, we're talking about the nervous system. However, the peripheral nervous system does not contribute to the creation of the electrical cardiac impulse at the SA node. In other words, it can adjust the heart rate up or down with a sympathetic or a parasympathetic response, but it does not contribute with the normal cardiac functioning of the heart. The SA node, once again, is the natural primary pacemaker of the heart. So how does the electrical conduction occur? It occurs from the SA node to both atria, principally in the right atrium, but it also goes to the left atrium through what is called the Baxman's bundle, because the left atria also needs to contract. Okay? So this is important. Does this make sense so far? Does it make sense? Okay, so the electrical conduction go from the SA node to both atria, And then from the SA node, the electrical impulse travels through internodal tracts to find the AV node, the atrioventricular node. Here you can see the internodal tract. We have the posterior internodal tract, the middle internodal tract, and the anterior internodal tract. This is what's going to carry the impulse from the SA node to the AV node to the atrioventricular node, which is located in the right atrium as well. You should know that the AV node manages a much lower velocity in comparison to the SA node. The velocity of the impulse through the AV node is approximately 20 to 40 beats per minute. And you may ask, why? Why is it a little bit slower at the AV node than the SA node? And the reason because this decrease in the rate is necessary to complete diastole in the cardiac cycle in order to promote what is known as a complete ventricular filling. This explains the deceleration of the electrical cardiac impulse at this level, and if you look at an EKG, you're going to see that this reflected as the PR interval. Okay, this decrease is the PR interval. All right. Now, what happens? Where does it go from the AV node? The electrical conduction follows the bundle of His into the interventricular septum, and then it's going to split into the right bundle branch and left bundle branch. Okay? So the right bundle branch is going to send the impulse to the right ventricle, and the left bundle branch is going to send the impulse to the left ventricle. From there, every bundle branch will end at the Purkinje fibers. And basically, the Purkinje fibers facilitate ventricular cardiac cells to be stimulated in order to produce an effective ventricular contraction or ventricular systole. The fastest cardiac electrical conduction occurs here in the Purkinje fibers. And the reason is to facilitate a complete ventricular stimulation and symmetric ventricular contraction. Now, we talked about there are certain things going on that influence the heart rate and contractility. And you have to know these three important properties: the chronotropic property, the dromotropic property, and the inotropic property. Why is this important to know for you as a nurse? Because certain medications affect these properties: the chronotropic, dromotropic, and inotropic properties. The heart is able to control its force of contraction. This is known as the inotropic property. It's also able to control the velocity of the electrical conduction. This is known as the dromotropic property. And can also control the rate of the conduction, known as the chronotropic property. Okay? There are many influences over the heart that can affect these properties. For example, drugs, electrolytes, hormones, toxins. But in normal condition, the heart is able to regulate its own with these properties. Now, we talked earlier about sympathetic response and parasympathetic response? Well, if there is stimulation of the sympathetic nervous system, the result is going to be a positive chronotropic action. In other words, an increased heart rate. This happens, for example, if a dog is running after you, you're running away. The fight or flight response, that is a sympathetic action. So basically, what's going to happen? Increase heart rate. Why increase heart rate? Because if we're running away from a lion or a dog or whatever is chasing you, you need the heart to pump oxygenated blood to those muscles. So the sympathetic nervous system stimulates that positive chronotropic property, increasing the heart rate. But also, there's going to be an increase in the atrioventricular conduction, known as a positive dromotropic effect. And then we also need, in a sympathetic stimulation, we need increase in the force of the myocardial contraction, the force, stronger force on the heart muscle. A sympathetic stimulation is also going to constrict peripheral blood vessels and therefore increasing the blood pressure. So now you understand why in a sympathetic stimulation the heart responds this way. Is it making sense how the sympathetic nervous system increases the heart rate, increases the atrioventricular conduction, and also increases the force of contractility? Is that making sense? All right. So let's continue. What else? What else can we learn? Well, what happens if instead of seeing a sympathetic stimulation, there is a parasympathetic effect? Well, parasympathetic nerve fibers are also attached to the heart and arteries. In a parasympathetic stimulation, we're going to see that it's going to reduce the heart rate, known as a negative chronotropic effect. It's also going to reduce the atrioventricular conduction, known as a negative dromotropic effect. Now, we understand now what is going on, why there is bradycardia, but what are some known causes of bradycardia? Number one, lower metabolic needs. For example, if you're sleeping, you don't need a very high metabolic demand. So the heart rate tends to decrease. So your heart rate should be lower when you're sleeping than when you're walking around the house or when you're working, or even if you start doing some athletic training. Now, as we spoke already, there is very high-end athletes that go through extensive training. They can also experience bradycardia, but usually asymptomatic, without symptoms. Also, conditions such as hypothyroidism, we can see bradycardia. Also, if there is vagostimulation, that will decrease the heart rate. Vomiting, suctioning, or severe pain. And although in severe pain, we can also see tachycardia. Certain medications is another cause. Administration of medications such as calcium channel blockers, nifedipine, amiodarone, beta blockers like metoprolol, and opioids and sedative. Also, idiopathic sinus node dysfunction can cause bradycardia. Increased intracranial pressure, coronary artery disease, especially myocardial infarction of the inferior wall tends to create bradycardia. Inflammatory conditions of the heart tissue, examples like myocarditis, rheumatic fever, or even lupus, systemic lupus erythematosus. And lastly, hypoxemia. Okay? And of course, if there is acute altered mental status or acute decompressed or decompensated heart failure, we can also see bradycardia. What are some known risk factors for bradycardia? Older age, high blood pressure, smoking, heavy alcohol use, use of recreational drugs, stress, and anxiety. Okay? And again, in anxiety, we can also see tachycardia. Some of these conditions, we can see both ends, bradycardia and tachycardia. What are the complications of bradycardia? Syncope, frequent syncope, heart failure, and sudden cardiac arrest. Now, if you are taking care of a patient with bradycardia, what are assessment findings that you're going to see? Well, the first assessment finding is a heart rate below 60. Remember, the normal heart rate in an adult, and we're talking of an adult, is 60 to 100. If the heart rate is below 60, this is bradycardia. The patient can be asymptomatic, no symptoms, but also the patient can show symptoms. Why is this important for an NCLEX question? If they're telling you that the patient has bradycardia, but there is no symptoms, usually your answer is going to be continue to monitor. But if the patient has bradycardia with symptoms, then we have to think of an intervention, whether it is a pharmacological intervention with medication or electrical stimulation. What are some known symptoms seen in bradycardia? Angina, chest pain, hypotension, memory problems, dizziness and lightheadedness, very frequent, syncope, a syncopal episode, tiredness, fatigue, shortness of breath, and even changes on the EKG. For example, ST segment changes, premature ventricular contractions, PVCs, and we can even see a bundle branch block. We could see different type of heart blocks. And I'll make sure I do another live to talk about the different heart blocks. What are you going to do if you have a patient with bradycardia? Well, the first thing you need to do is determine the cause. For example, if the cause is a medication, let's say you gave a patient metoprolol, a beta blocker, and the heart rate decreased too much, then we need to think of holding that medication and then calling the doctor. Sometimes the bradycardia can be because the patient is hypoxic. Patients with breathing problems, hypoxemia. Sometimes giving oxygen is sufficient to correct the bradycardia. We have to think of pharmacological administration of atropine sulfate to increase the heart rate to at least back to normal, 60 beats per minute. If the pharmacological intervention, if medication is not effective, then we need to be prepared for a transcutaneous pacemaker. Basically, we try to do the pharmacological intervention first, and if that's not effective, then we try the non-pharmacological approach with a transcutaneous pacemaker. Remember, be careful with the administration of atropine sulfate, because if you give too much atropine, then we can put the patient in the opposite, which is tachycardia. Let me Let me change this real quick so you can see it a little bit better. 1 second. There you go. It should be a little bit better there. Okay. We're also going to monitor for hypotension and administer fluid intravenously as prescribed. Depending on the cause of bradycardia, the patient may require a more permanent intervention, such as a permanent pacemaker. I want to show you this approach to sinus bradycardia in adults. Remember, we're talking in adults. This is a very nice drawing from UWorld that I wanted to share. Basically, sinus bradycardia, we're going to see a patient with a heart rate of less than 60, less than 50, we start seeing symptoms such as dizziness. We're going to assess the patient generally. How is the patient responding to this bradycardia? We're going to try to identify the underlying cause and treat the underlying cause. Make sure the patient has an IV access. Monitor the patient's cardiac rhythm continuously. Check the O2 saturation and do a 12 lead EKG, but we should not delay treatment waiting for a 12 lead EKG. Now, the algorithm says if the patient has bradycardia and one of the following, hypotension or signs of shock, acute mental starter changes, chest discomfort, or acute heart failure, we're going to take one of these approaches here. If the patient has bradycardia sustained but has none of the symptoms, then the answer is going to be monitor. Continue to monitor. But if the patient has bradycardia with any of those symptoms, hypotension, acute mental starter changes, acute heart failure, chest discomfort, then approach number 1, intravenous atropine. 1 milligram, the first dose, and we're going to repeat every 3 to 5 minutes to up to 3 milligrams maximum. Let's say you gave IV atropine, 1 milligram, doesn't get better. 5 minutes later, another milligram, doesn't get better. A third milligram of atropine, no response. Then we have to try another approach. Transcutaneous pacing, or we can try one of these strips. Administration of dopamine, vasopressor, or administration of epinephrine. And we assess the patient. If we still have no response, then we need an expert consultation and transvenous pacing. So it's very important to understand this algorithm. Okay? I see Ms. Ginani Baldwin, Professor, do you have an English classes in person for NCLEX review? You mean like one-to-one tutoring? We have different programs. I'll give you the number to our academy so you can call us and I can follow up on that, okay? All right. So let's go back to the question. The patient has sinus bradycardia and the blood pressure is 90/60 with a heart rate of 46. Let's stop here. Because we've already learned that the interventions is going to depend on whether the patient has symptoms or not. So in this scenario, is the patient with bradycardia having symptoms? Yes. What are the symptoms? Bradycardia with hypotension. Because the systolic blood pressure is 90, which is low, and the diastolic blood pressure is 40, which is low. We don't have any other symptoms here, but with that low blood pressure, we're probably going to have neurological changes as well. But it's not described in the scenario. What am I going to do? Number 1, give the scheduled dose of metoprolol 50 milligrams orally. Well, what is going to be the effect of metoprolol? Metoprolol is a beta blocker. So this is going to further decrease the heart rate. This is an incorrect answer. Number 2, instruct the client to cough forcibly. So, to cough strong. Well, we talked about this. If the patient holds their breath or is coughing forcibly, what we're going to see? We're going to see a vasovagal reaction. Vagus nerve stimulation. And that can further reduce the heart rate. So number 2 is not the answer. Number 3, very interesting. Very interesting. If you don't read carefully, you could select this answer by mistake. Why? Because it says, place the client in reverse, keyword, reverse Trendelenburg position. Why you could get confused here? Well, the patient is hypotensive. And we know that some of the interventions in a hypotensive patient is to place the patient in Trendelenburg. Yes, Trendelenburg, yes, but not reverse Trendelenburg. So number 3 is incorrect. So it looks like my answer is going to be 4. Prepare to administer atropine, intravenous push. Well, we talked. You know this already. After this presentation, this answer should be very, very easy. Why administer atropine? Well, the patient has symptomatic bradycardia, and symptomatic bradycardia is treated initially with intravenous atropine, 1 milligram, and reassess 3 to 5 minutes, another milligram, 3 to 5 minutes assessment, and then another milligram. No response, then we go to transcutaneous pacing, administration of dopamine or epinephrine, and if it's still not good, then we need a cardiology consultation. So, what do you think? What do you think so far? Are you enjoying this training? If you are, make sure you like our videos. Make sure you like this live right here. There's 107 of you live now. Make sure each one of you click the like button to help us out. If you want to see more of these live trainings, if you want us to come back, support our channel by liking us, sharing it with other nurses, and that is going to be your way of telling us, thank you, Professor. If you're looking for a mentor, we have a very inexpensive membership. It's a small membership, 50, 60 videos. You can use it for a few months, and it will teach you on how to prepare for the NCLEX, critical thinking strategies. If you are a Spanish speaker, if you're here watching this live and you speak Spanish, Spanish is your primary language, and English is a little bit difficult for you, we have a Spanish membership. It's called our Gold membership. Excellent. More than 177 videos with 3 different courses. Content course, a critical thinking strategy course with a bunch of questions that you can practice on video format. Here is the number to contact our academy. If you need help with NCLEX preparation but you speak English, call the English advisor. If you need to speak with our Spanish advisor, here is the number as well. And at the same time, if you have any difficulty with the process of documentation, in our academy we have somebody that can help you as well. So whether if you need NCLEX training or you need help with documentation, we are here to help you. Thank you for joining us. Come back tomorrow tomorrow, I think tomorrow's training is going to be about cardiac catheterization. So if you're having any issues with cardiac catheterization, how to recognize when it's a right or left cardiac catheterization, what are the complications, come back and I will help you with this as well.